Hello everyone, welcome again. Now we have finished the diagnostic procedures, how to do proper diagnosis. Now I'm ready to identify my condition. So diagnosis, it should consist of two diagnoses, not one. It should consist of the diagnosis to the pulp and diagnosis to the periapical area. So the American Association of Endodontists, it have mentioned that there are 7 types of pulp condition and 6 types of periapical conditions. Mostly your case, it will fit one of these cases. So let's see first the pulp conditions. The state of the normal pulp. Mostly there's no source of pain, it's a symptom-free. Pulp testing, it gives a normal response like a sharp momentary pain that will subside after removal of the stimulus. Within the radiograph, the periapical radiograph, it shows nothing in the periapical area, no changes in the periapical area. Lamina dura is intact, no widening in the periodontal membrane space. The periapical testing, it's normal. Percussion is normal, palpation is normal. Periapical X-ray, it shows nothing changes in the periapical X-ray. The other condition is the reversible pulpitis, where there will be like the patient complains from momentary pain with some stimulus like drinking cold or drinking hot, mostly with cold rather than hot, and of course with sweet, okay? Mostly you will find a source of etiology of this pain like presence of caries or presence of deep restoration. Other symptoms, there could be like a mild or moderate pain within drinking of something cold or hot. Radiographically, there will never be changes in the radiograph, okay? Why we mention this as a reversible pulpitis case? Because if I remove the cause of the irritation, like removal of caries, whenever there's no communication with the oral cavity, there's no entrance of bacteria to the pulp chamber and root canals. So if I manage to remove the caries and fill this canal fill this cavity by a restoration, the pulp, it can recover back to its normal state, and that's why it is mentioned as reversible pulpitis. Another condition, which is the irreversible pulpitis, and from its name, it is irreversible. Whenever the damage to the pulp occurred, okay, should be removed, the pulp should be removed, and root canal treatment, it should be done. So irreversible pulpitis, it can be divided into 2 types. One of them is the symptomatic irreversible pulpitis, and another type, which is the asymptomatic irreversible pulpitis. Symptomatic irreversible pulpitis is one of the very familiar causes of root canal treatment in our clinic. Here, the pulp is inflamed beyond the capacity of repair or healing of the body, okay? So mostly you will find that there's a carious tooth or deep carious tooth, a recent restoration, a recent preparation, for example, a recent fracture, a recent trauma. All of this could be a causes of etiology of symptomatic irreversible pulpitis. There are some characteristic features of symptomatic irreversible, like sharp pain, lingering pain, okay, prolonged pain after the stimulus, spontaneity of the pain. The pain can come without any stimulus, okay? Pain can increase at night, especially when lying down, where the blood will go more to the head and increase what we call the intrapulpal pressures. Okay, referred pain is also one of the characteristic features of the symptomatic irreversible pulpitis. Analgesics here, mostly in the late stages of symptomatic irreversible, it will be ineffective. Asymptomatic irreversible pulpitis. This means that the pulp is irreversibly damaged, but again, there's no symptoms. This is characterized by no pain, no symptoms here in this tooth. You can find that there's some sort of etiology, again, like deep caries or trauma or recent filling, okay? Or Pulp testing here also, it will show normal appearance. There's no loss of vitality. The pulp is normal. Mostly the asymptomatic irreversible pulpitis, it will turn one day either to be a pulp necrosis or it will go to be asymptomatic irreversible pulpitis. So the state of asymptomatic, it will not last mostly for long. Another condition, which is the pulp necrosis, like for example, cases of trauma. They're very familiar with the cases of trauma, especially in the maxillary central incisors because they are more prone to trauma. The fractured teeth, the carious teeth, okay? The cases of pulp necrosis, it could be with no pain, asymptomatic, or it could be with moderate pain, or it could be with severe pain if there's an extension to the periodontal ligament and inflammation of the periodontal ligament. Pulp testing, mostly it will give no response, okay? The percussion test, it can give pain on percussion or not according to the extension of inflammation to the periodontal ligament. What about the radiographic changes? That could be like just a thickening or widening in the periodontal brain space, or it can give a clear periapical radiolucency in the radiograph. Another condition, which is a previously treated tooth. Either this tooth have been properly root canal treated or improperly root canal treated. It is mentioned as previously treated tooth. This case, it could be painful or non-painful according to the state of the periodontal ligament. Previously initiated, mostly here, access cavity and pulpotomy or pulpectomy have been done. The pulp have been removed, okay, but it never been obturated, okay. So these are the pulp condition. What about the periapical condition? Again, we will start with the normal apical tissue, okay, where there's nothing in the case, the periapical tissue is normal. The lamina dura is intact. The periodontal membrane space is within normal limits. No evidence of bone resorption at the periapical region. There's also no sensitivity to percussion. Again, what about the periodontitis or the apical periodontitis inflammation in the periapical lesion or the periodontal ligament? This can be divided, as we done in the pulp, it can be divided in the apical area into symptomatic apical periodontitis and asymptomatic apical periodontitis. So the symptomatic apical periodontitis, one also of the most familiar cases in the dental clinic. Whenever there's an inflammation in the pulp and extension of the inflammation to the periodontal ligament, there will be inflammation in the periodontal ligament. It is characterized by pain on percussion or pain on mastication or sometimes pain on palpation, okay? This case, you can see sometimes widening in the periodontal membrane space, or sometimes you can see nothing, or you can see like starting to have a periapical lesion. This case, it could be vital or non-vital, okay? Yani the symptomatic apical periodontitis, it could be accompanied with the vital cases or the non-vital cases. The asymptomatic apical periodontitis, from its name, it's asymptomatic. There's no pain on percussion. It's just presence of apical radiolucency, okay? What the patient can feel that this tooth is slightly different from other teeth, but there is no pain. That's why it is named as an asymptomatic apical periodontitis. Other condition we are familiar with, and we see it a lot in the dental clinic, which is the acute apical abscess. Acute apical abscess is characterized by that it is rapid onset, okay, and it's characterized by formation of pus, okay. The pain here, it could be a spontaneous pain, okay. The patient will feel like severe pain on biting or pain on percussion or pain on palpation, okay. The vitality testing here, it will give you negative response. There's loss of vitality. For the apical abscess to be formed, the pulp, it should be first necrotic pulp, okay? So it's characterized by formation of pus, sometimes swelling, Okay, what about the radiographic feature? The abscess, the acute apical abscess. It could be just widening in the periodontal membrane space, or it can be periapical, or it can be manifested as periapical radiolucency if it is like acute exacerbation of chronic abscess. It started as a chronic abscess, and due to some condition, it flared up to be acute apical abscess, and then it will show like a periapical radiolucency. Sometimes cases of acute apical abscess, it's characterized by lymphadenopathy and sometimes fever or increase in the body temperature. One of the other conditions, or the periapical condition, is the chronic apical abscess. It's characterized by necrotic pulp. Mostly there's no pain on percussion or on mastication, or the patient complains of nothing. It's characterized by presence of a sinus tract. Okay, so if I put like a gataperca in this sinus tract, it will point to the tooth which I'm suspecting, or the tooth where there's a pulp necrosis causing the periapical chronic abscess. Radiographically, chronic apical abscess characterized by formation of periapical radiolucency. The last condition of the periapical condition is the condensing osteitis, and this is like a defensive mechanism of the body, where the body, it will form bone rather than destruct the bone, and mostly it occurs where there's a high immunity, especially in the young ages. Thank you, and next time we are going to talk about the emergency condition in endodontics. Thank you.